In this talk, I want to give you guys a solid introduction to prostate MRI and briefly discuss PI-RADS. We won't have time to discuss the finer details of PI-RADS, but I've included a link to the PI-RADS document in the description below the video that you can read if you're interested. But in this video, the focus is going to be to give you what you need to start reading prostate MRI. And to do that, we're going to have to go through a bit of background, including what a typical prostate MRI protocol includes, and then we'll look at MRI images together to go over basic anatomy, some common benign findings so you know what normal looks like. We'll talk about what cancer typically looks like, and then we'll review PI-RADS scoring. At the end, we'll go through an approach to prostate MRI, and then we'll apply what we've learned in a couple of cases. Before watching, I strongly suggest you watch the Introduction to Abdominal MRI video, which covers some clinically relevant MRI principles that you need to know. So why is this topic important? Well, prostate cancer, as you know, is very common. It's one of the most common cancers in men. But a good proportion of prostate cancers are considered clinically insignificant. These are cancers that have very low metastatic potential and are cancers that men will often die with rather than die of. And then, of course, there are prostate cancers that are more aggressive or considered clinically significant, and these need to be treated. So our goal is to improve detection of clinically significant prostate cancers before they spread so that they can be treated. So how do we define which lesions are clinically significant? One of the things that we can look at is the Gleason grade. Put simply, remember, as most of you know, when we use the word staging, we're talking about where the tumor has spread. And when we use the word grade or grading, we're talking about how abnormal the cells actually look. And an important concept for prostate cancer is the most common tumor grading system that we call the Gleason score. This is a score based on the microscopic appearance of the glands in the tumor, where 5 is the most aggressive or highest score. And the overall Gleason score is the sum of the two most common grade patterns, expressed as the most common pattern first. So the maximum is a 5+5 or Gleason 10 lesion. Also, since the most common pattern is expressed first, a 4+3 lesion is more aggressive than a 3+4 cancer, even though both have a total Gleason score of 7. And so how do we define clinically significant prostate cancer? Well, unfortunately, there's really no standard definition, but the definition used in PI-RADS is up here on the slide. An easy but definitely oversimplified way to think about it is Gleason 7 or higher is going to be clinically significant, and Gleason 6 is highly unlikely to be clinically significant. And what is interesting is that prostate MRI is actually pretty good at identifying clinically significant prostate cancer with sensitivities and specificities around 80% in the literature. So that brings us to prostate MRI. And I don't want to go through a whole history lesson here, but essentially prostate MRI used to really only be used for staging in patients with known cancer. With advances in technology, there has been improvement in detection of clinically significant prostate cancer with MRI. So now, it's not only used for staging, but also used to detect clinically significant prostate cancer, characterize it, and provide image guidance for biopsy or focal therapy. And then, to standardize all of this, we have PI-RADS, which stands for the Prostate Imaging Reporting and Data System. And this first came out in 2012 and then was subsequently updated with version 2 in 2015 and then recently version 2.1 in 2019. Ultimately, this is designed to standardize all things prostate MRI, mainly the acquisition, interpretation, and reporting of prostate MRI studies. Although we're briefly going to talk about some of this today, we're going to mainly focus on the interpretation piece. It's important to know that PI-RADS version 2 first introduced a simple, algorithmic approach to interpreting prostate MRI, essentially simplified rules that included specifying the dominant sequence in each zone, namely diffusion-weighted imaging in the PZ or peripheral zone and T2-weighted imaging in the TZ or transition zone. Version 2.1 made further updates and attempts to make further improvements to this, mainly based on some of the shortcomings in version 2. And once we go through some of the basics, we're going to review the version 2.1 algorithm. But first, what does a typical prostate MRI protocol look like? What images do we acquire, and what images are we looking at when we look at a study? Well, first of all, prostate MRI can be performed on a 1.5 or 3 Tesla magnet, though 3T is preferred in most situations. At minimum, a multiparametric prostate MRI examination should include the following sequences: a T2 weighted axial sequence, generally a small field of view to cover the prostate and seminal vesicles only, like this one we have over here, where you can nicely see the zonal anatomy with the TZ and the PZ, and we'll get to that later. And then a T2 weighted sequence in at least one orthogonal plane, so coronal or sagittal, or both. Next, very importantly, we need to acquire diffusion-weighted images, and specifically with a high B-value. So PI-RADS specifies a B-value of 1400 or higher. ADC maps are also calculated based on 2 lower B-value acquisitions. If some of this isn't making sense, again, I suggest watching the Intro to Abdominal MRI video to understand some key basic MRI concepts. You also want to acquire a T1 weighted pre-contrast image, mainly to look for hemorrhage, and then dynamic post-contrast acquisitions, or DCE images. These are usually rapid T1 weighted gradient echo sequences that are acquired before, during, and after gadolinium is given, with a temporal resolution of less than 15 seconds for at least 2 minutes. And lastly, at least one sequence should cover a larger field of view to the level of the aortic bifurcation. For example, at our institution, we perform a delayed post-contrast acquisition of the pelvis to look for lymph nodes, but other institutions may acquire a wider field of view T2 weighted sequence. If this is complicated, take a step back and think of it like this. Essentially, you have your T2 weighted sequences. This is a T2 weighted axial sequence here. You have your diffusion weighted images. Here you have a high B-value DWI sequence on the left and the ADC map on the right. You have your T1 pre and then dynamic post-contrast images with the DCE image shown here, and then at least one wider field of view image to look for nodes. Okay, so now let's look at a real prostate MRI study, look at the sequences, and then look at some basic anatomy. Okay, so this is a prostate MRI. So again, a protocol will include our T2 weighted images, so our axial T2 weighted image here of the prostate. You can see how you can see the zonal anatomy quite nicely. Here's an example of a coronal T2 weighted image, so we want at least one orthogonal plane. So then we have our diffusion weighted images, so we have our high B-value DWI acquisition here, and our ADC map down here. Okay, and then we want our T1 pre-contrast study. So you can see the prostate here, generally looking for hemorrhage. And then we have our dynamic post-contrast study before, during, and after gadolinium administration. Then we have one wide field of view acquisition. So this is from at least above the aortic bifurcation and of the entire pelvis to look for lymph nodes as well as other abnormalities, including looking at the bones. And so those are the core sequences that we need to acquire when we're doing a prostate MRI. So let's now talk a little bit more about the anatomy, and we'll start with the prostate itself. So first, we separate the gland into 3 levels. So we have from superior to inferior the base of the prostate, the midgland or mid prostate, and then the apex at the bottom or inferiorly. And you'll notice that again on these T2 weighted images you can see the zonal anatomy quite well. So we have our TZ or transition zone here with these BPH changes, and we have our peripheral zone or PZ out here. So generally, the peripheral zone on T2 weighted images is pretty homogeneously T2 hyperintense, okay? And the vast majority of prostate cancers, about 75%, are going to happen in the PZ or peripheral zone. In the transition zone or TZ, about 25% of the cancers are going to happen here. And so again, the TZ is the site of all of these BPH changes or benign prostatic hyperplasia changes, and we'll talk about what that looks like a little bit more later. So all of these changes here are BPH changes. Anteriorly, although it's compressed here, we have the anterior fibromuscular stroma. Okay, and the anterior fibromuscular stroma has no glandular tissue, so it's going to be completely T2 hypointense. And posteriorly, we have the central zone, or CZ, which are these paired, wedged-shaped T2 hypointense areas that are posterior and surrounding the ejaculatory ducts. If I show you the coronal images here, this here is central zone. Okay, and you can really appreciate the wedge-shaped nature. When there are less BPH changes, it may come more inferiorly like this, but again, it should be pretty well defined and wedge-shaped rather than have any convex borders here as well. And so this is important to know because one could easily, at least on these T2 weighted images, think that there is something here in the PZ. But if you know your normal anatomy, you know that this is just compressed CZ or central zone. And then each of these zones, so the TZ, PZ, CZ, and anterior fibromuscular stroma, so the 4 of them, can be separated into sectors. And we'll talk about the sector map a little bit more. But very briefly, the most important are that the transition zone can be split into anterior and posterior TZ at each of the base, mid, and apex for both the right and the left gland. And the peripheral zone can be separated into the anterior, posterior lateral, and posterior medial gland on each side, again at the base, mid gland, and apex. One thing that's important to know about the prostate is that it's actually not surrounded by a true capsule. Although people will often refer to cancer spreading out of the prostate as extracapsular extension, there's really no actual true capsule here. Instead, there is a condensation of pelvic fascia along the periphery, and you can see this T2 hypointense band here. Another structure that people like to refer to is this hypointense line between the TZ and the PZ, and that is referred to as the surgical capsule or pseudocapsule. Again, that's just compressed tissue. Other anatomy that I want to point out on the sequence includes the seminal vesicles here. So we have the right seminal vesicle here and the left seminal vesicle over here. The neurovascular bundles run at the 5 and 7 o'clock position along the prostate and enter the prostate at the base and the apex. So those are potential areas of extraprostatic extension. This here is the bladder. So this is urine here, and this is the bladder wall. That's pretty T2 hypointense. Back here is the rectum. And then, of course, we have our nodal stations if we look at our wide field of view images. So we have our retroperitoneal nodes up here. We have our common iliac nodes that would be around the common iliac artery or common iliac vasculature. After the bifurcation, we have our external iliac nodes that run along the external iliac vessels, as well as the internal iliac nodes that are along the internal iliac vessels. We have our obturator nodes here. Other important nodes to note are the mesorectal nodes, which are going to be around the rectum and we might see on our T2-weighted sequences, as well as our inguinal nodes here in the inguinal regions. And we'll talk about staging later, but the common iliac and retroperitoneal nodes are considered metastatic, as well as the inguinal nodes. And the internal and external iliac nodes, the presacral mesorectal nodes, obturator nodes, and periprostatic nodes are considered to be regional nodes. One important thing to understand about prostate anatomy is the sector map. This is important to understand to be able to communicate the location of an abnormality that you spot in the prostate. And so the prostate sector map is included here with the sectors described here on the left. But if you're going to remember anything, try to simplify it. The TZ is split into an anterior and posterior sector at each level, namely the base, the mid, and the apex. And the PZ is split into the anterior, posterior lateral, and posterior medial at each level of the base, the mid, and the apex. And of course, you're going to have these on each side, so on the right and on the left. You also have your anterior fibromuscular stroma here in blue at each of the base, the mid, and the apex. And then you have your CZ or central zone here as well on each side. If these numbers and this sector map looks too confusing, again, just simplify it. For the vast majority of lesions, you're just going to need to know how to split up the TZ and PZ. Again, the TZ into two with the anterior and posterior at each level, and then the PZ with the anterior, posterior lateral, and posterior medial at each level. A very basic principle that you need to understand is what most prostate cancer looks like. What are we looking for when we're looking at prostate imaging? Well, most of the tumors that we image are going to, one, restrict diffusion, so they're going to be bright on high B-value DWI, and they're going to be dark on ADC maps. They're generally going to be homogeneously T2 hypointense, and with gadolinium, they're going to enhance. So this is an example of a cancer. So you have your T2-weighted image here, you have your ADC map and your DWI, and we have a cancer here that is hyperintense on the high B-value DWI and hypointense on the ADC map. It's in the posterior lateral peripheral zone here, and it's homogeneously T2 hypointense. Of course, it's not always that simple, and that's why we have PI-RADS. And PI-RADS has specific ways to describe lesions on each of the sequences, and a simplified algorithm that helps us assign a PI-RADS assessment category indicating how likely clinically significant prostate cancer is for that particular lesion. And these PI-RADS scores from 1 to 5, again, indicate the likelihood that the findings on MRI correlate with the presence of clinically significant prostate cancer for any particular prostatic lesion. Again, from 1, which is very low likelihood, to 5, which is very high likelihood. So now that we know some basic anatomy and what tumors might look like, it's important that we get a good feel for what normal looks like. More specifically, understanding what the common benign findings are, and that will help us better see cancer when it's there. So let's discuss some common benign findings by looking at some pictures. Firstly, and most importantly, let's talk about BPH changes, or benign prostatic hyperplasia. So BPH changes happen in response to testosterone, and the changes themselves arise in the transition zone, or TZ, though occasionally you can get extruded nodules into the PZ. BPH changes themselves consist of stromal and glandular hyperplasia, and they can look like well-circumscribed nodules, encapsulated nodules, and band-like areas. And what they look like is going to depend on what they're made of. So glandular BPH changes and areas of cystic atrophy, of course, are going to be pretty T2 hyperintense or bright. And stromal BPH changes are going to be pretty T2 hypointense, but typically are very circumscribed. So here, for example, we have BPH changes that are glandular, that's completely encapsulated. Here is an example of a stromal nodule. It's T2 hypointense, but it's quite circumscribed. And we have another one here on the left. So all of this here in this patient, these are all BPH changes, and it's pretty heterogeneous. So it can sometimes be hard to pick out cancers. And later we'll talk a little bit more in detail about what you're actually looking for amongst these BPH changes. It is worth noting that with contrast, BPH changes are quite variable, and that's why DCE is not part of the algorithm for the TZ, and we'll talk about that later. And they can also be pretty variable with respect to their DWI signal as well. Next, we have hemorrhage, and hemorrhage is commonly seen in the prostate, especially if the patient had a recent biopsy. Usually we're going to see that as T1 hyperintensity, like this here. So this is a T1 pre-contrast image, and you can see there's hemorrhage here in the gland. Next, we'll talk a little bit about prostatitis, or inflammation in the prostate gland itself. So prostatitis is actually pretty common, but often subclinical. And this can range from mild changes with kind of diffusely decreased T2 signal in the normal PZ, and it can occasionally demonstrate enhancement on the post-contrast images and some diffusion-weighted changes, and this can result in false positives and can be confusing and mimic cancer. But the key is that most prostatitis changes in the PZ are usually band-like, linear, or wedged shaped. So prostatitis is less often focal, round, oval, or markedly restricting. And although certain types of prostatitis can do this, if you see anything in the PZ that's focal, round, oval, or markedly restricting, you should never call it prostatitis. But we're going to go through the algorithm in a bit and take you through some cases, and this will all become very clear. For now, just think of prostatitis as linear or wedge-shaped T2 hypointensity and mild changes on other sequences. More chronic changes of prostatitis can lead to areas of atrophy with volume loss and bands of low T2 signal as well. Other clearly benign changes include cystic changes like this cystic lesion here. And like elsewhere in the body, they're going to be generally T2 pretty hyperintense and T1 hypointense, non-enhancing and non-restricting, and calcifications, which are much more obvious on CT and generally dark on all sequences. Calcifications and cysts don't look like cancer at all, so are less frequently commented on MRI. Okay, now that we have a better idea of what normal and benign look like, let's talk about the PI-RADS scoring algorithm to help us pick out the lesions that we think are cancer. So there are two different algorithms depending on where the lesion is located. One for the PZ lesions or peripheral zone lesions on the left here, and another for TZ lesions or transition zones here on the right. And we're going to go through each of them in detail. But just looking at the diagram here first, you'll notice that here in red we have the final PI-RADS categories. As we mentioned, 1 being very unlikely to have clinically significant prostate cancer and 5 being very likely. In practice, a 4 or 5 is considered positive and generally biopsied. A 1 or 2 is generally considered negative and often ignored. And how 3s are dealt with is dependent on the institution. It is quite variable. But for now, it's good to think of PI-RADS 3 lesions as suspicious as well and often biopsied. You'll immediately notice that for PZ lesions here, the DWI score is the main thing that determines the final PI-RADS score. So essentially, the main determining sequence in the PZ is the DWI score, and the main sequences you're going to look at are the high B-value DWI sequence as well as the ADC maps. For TZ lesions, you'll notice that the final scores are predominantly determined by the T2 weighted image score. So the T2 weighted images are the most important sequence in the TZ. Let's talk about these in a little bit more depth, starting with the PZ lesions. So first of all, as we said earlier, in the PZ, the primary determining sequences are the diffusion-weighted sequences, okay? And so we need to look at the DWI score. So the DWI score ranges from 1 to 5. A score of 1 is normal or no abnormality. A score of 2 refers to linear or wedge-shaped diffusion abnormality, and this is meant to capture cases of prostatitis, which is benign. And then from 3 to 5, we have focal diffusion signal abnormality. It's important to first focus on scores 4 and 5, which correspond to markedly high signal on high B-value diffusion-weighted images and markedly low signal on ADC maps. A score of 5 is reserved for marked diffusion restriction that's over 1.5 centimeters in size. Also, if there is definite EPE or extra prostatic extension, that automatically makes it a 5 regardless of the size. It's important to note that PI-RADS defines markedly restricting a signal abnormality that is more pronounced than any other focus in the same zone. Okay, so some people have tried to quantitate this in the past with cutoff ADC values ranging from 750 to 900. Obviously, the lower the ADC value, the more restricting. So ADC values lower than a cutoff would correspond to a markedly restricting lesion. So if you remember one thing from this, the takeaway is that you're going to be looking for focal, markedly low signal on ADC, and focal, markedly high signal on high B-value DWI images in the PZ to get that score 4 or 5. The other sequence that matters in the PZ, for scoring at least, is DCE, or the dynamic post-contrast sequences. And DCE is dichotomous, so it's scored as either positive or negative. A positive score is focal enhancement that's either early or contemporaneous with the rest of the gland. So an enhancing focal lesion at the same location as diffusion abnormality that enhances either early or at the same time as the rest of the gland. So if we go back to our algorithm here, you can pause the video at this point if you want to review the descriptions here on the right that we just covered. But you're going to see again that the DWI score determines the final PI-RADS score, and for a DWI score of 3, a positive DCE can upgrade the final category to a category of 4. So this is the PZ algorithm that you need to know, and we're going to revisit this when we go through our approach and when we go through a couple cases. Okay, so now let's talk about the TZ, which can be a little bit more complex and a little bit more challenging. Again, the primary sequences in the TZ are the T2 weighted sequences. So a score of 1 refers to a normal TZ, which is pretty rare in older patients that we're imaging because most people have BPH changes or benign prostatic hyperplasia changes in the TZ. Okay, so in PI-RADS version 2.1, typical BPH nodules are also included as lesions that are scored as a T2 weighted score of 1. Okay, and this is specifically referring to BPH nodules or nodules in the TZ that are encapsulated or completely encapsulated. And so this is a T2 dark rim that you're going to see all the way around the nodule, and it's going to look something like this schematic over here. A score of 2 refers to atypical BPH nodules, namely things that are mostly encapsulated, like this image up here, or homogeneous and circumscribed, like this nodule over here, but without encapsulation. Again, these are considered to be BPH changes and are benign and are assigned a score of 2. The last descriptor here in this family is homogeneous, mildly hypointense signal that are between 2 BPH nodules. as shown here in this schematic. When it comes to the higher scores, the most important thing to know is what we're looking for when we're looking for cancer, or what cancer looks like in the TZ. So again, I'm going to get you to focus on the 4 and 5 scores. So a typical clinically significant cancer in the TZ is going to look homogeneously T2, moderately hypointense. They're often non-circumscribed or lenticular in shape. Lenticular just meaning shaped like a lens. And those descriptors are what we talk about when we talk about a score of 4. So lenticular or non-circumscribed, homogeneous, and moderately hypointense on T2 weighted images. And this is an example of that here. A score of 5 is going to be similar to 4, but again, greater than 1.5 centimeters or definite extraprostatic extension. And this, again, is an example of our classic TZ cancer. It's homogeneous, it's lenticular, it's non-circumscribed, and it's moderately hypointense. Okay, so these are the BPH changes back here, and this clearly looks very different, and this is a classic TZ cancer, and that's the takeaway here. So the classic description or colloquial way to refer to this is an erased charcoal appearance or a smudgy fingerprint appearance. So burn this into your brain, an erased charcoal appearance or smudgy fingerprint appearance. This is the type of thing you're looking for amongst the BPH changes that we've talked about already, and we'll show you some examples of this again later. Now, the difficulty again is that clearly BPH changes are heterogeneous, so we need to be able to pick these out amongst the BPH changes, but again, we'll show you examples of this later. Lastly, a score of 3 refers to heterogeneous signal intensity with obscured margins, and also includes other things that don't meet the other criteria that are 2, 4, and 5. The other sequences that matter in the TZ are the diffusion-weighted sequences, and these are scored similar to the way they are in the PZ, but really all that's important is the score of 4 and 5. Again, marked restriction, so markedly hypointense on ADC maps and markedly hyperintense on high B-value DWI images. And again, this is the TZ algorithm, and you can pause the video if you'd like to review all of these descriptors here and the algorithm here. But again, the T2 score is what is primarily determining the final PI-RADS score, or final PI-RADS assessment category here in red. Very importantly, a T2 weighted score of 2 in the TZ, so that refers to those atypical BPH nodules that we described, can be upgraded to a final assessment category of 3 if they have marked diffusion restriction, so DWI score of 4 or 5. And a T2 weighted score of 3 can be upgraded to a final category of 4 if it's markedly restricting and over 1.5 centimeters or with extraprostatic extension, aka a DWI score of 5. When it comes to staging prostate cancer, some of the information is going to be here on the slide, but I just want to touch on what's most important when you're looking at an MRI study. So the first thing is determining if tumor is confined to the gland or if there's extraprostatic extension or EPE. So what do we look for when we're looking for EPE? So essentially when we say that there is something with frank extraprostatic extension, we're referring to clear cancer outside of the prostate. So there's direct tumor extension that's obviously outside of the prostate. If there's seminal vesicle invasion, that's clearly extraprostatic extension. If there's neurovascular bundle involvement, that's clearly extraprostatic extension. And then there are a bunch of softer signs that are predictive of EPE, but are not enough to say there is definite or frank EPE. And those things we still describe when we're describing the prostatic lesion. And those things include a broad capsular interface, so over 1 centimeter of contact with the capsule, or a focal bulge of the prostate contour at the location of the lesion. And then for lymph nodes, we're generally looking for enlarged or morphologically abnormal nodes, so round, heterogeneous nodes, etc. And if they're obviously involved, we're going to see that, But unfortunately, even some smaller nodes that look morphologically normal on MRI may be involved. So our job as radiologists are to point out the nodes that are obviously involved, aka enlarged or morphologically abnormal. In prostate cancer, it's important to know that the regional nodes include the periprostatic nodes, internal and external iliac nodes, presacral nodes as well. It's important to know that aggressive prostate cancers often spread to the mesorectal nodes posteriorly, and this is something that's expected. So it's not something that necessarily suggests that there's a rectal cancer or something else going on. We often will see aggressive prostate cancers spread posteriorly to the mesorectal nodes. And then we have our non-regional nodes that are actually considered metastatic, and that includes the common iliac nodes, the inguinal nodes, as well as retroperitoneal nodes higher up like para-aortic nodes. And then of course on every study we're also going to be looking at the nodes, specifically T1 weighted images or fat-only images are going to be great for looking for marrow replacing lesions or looking for suspicious lesions in the bones. Okay, in this part of the video, I'm going to take you through my approach to prostate MRI. Okay, so we're going to start by looking at this image in the bottom left corner here. And this is the pre-contrast T1 weighted image, clearly fat saturated. And generally we're looking for hemorrhage in the gland, so we're looking for T1 hyperintensity here, which we do not see, as well as in the seminal vesicles. Again, we don't see any hemorrhage here. Next, I generally measure or contour the gland depending on your institution to get the prostate volume and look at the PSA and then calculate the PSA density. But again, we're not going to talk about that much more here. Then I generally look at the T2 weighted images for anatomy of the prostate, looking at the TZ and PZ. So starting with the TZ, I'm looking at these BPH changes on either side and looking for anything that stands out and anything that looks like cancer. Okay? So these are all BPH changes here, including glandular BPH changes and stromal BPH changes, but there are no suspicious lesions here that would match the category 4 or 5 T2 weighted score in the TZ that are suspicious at this time at least. I then look at the PZ from apex to base on either side. We see some linear T2 weighted hypointensity here that looks like prostatitis, but I don't see any focal abnormalities. I'm also correlating any findings on the axial images with the coronal images over here. Okay, then I'm looking at the high B-value DWI images, looking for anything restricting, starting with the peripheral zone on either side, and we don't see anything that's markedly hyperintense there, as well as the TZ, which is again more variable. And then I look at the ADC map down here, again, starting with the PZ, looking for anything that's markedly hypointense. You can see that the gland here is quite hyperintense with some band-like signal that is not suspicious. You'll notice again, if you were to not know your anatomy, you might say, oh, what is this? Is this something that's restricting? Right, oh, it's a little bit bright here on the DWI, it's a little bit dark here. Then you notice, oh yeah, this correlates to normal CZ or central zone compressed up here. So again, the benefits of knowing your anatomy, this is not cancer, this is a normal structure. Lastly, with the prostate, I'm looking at the dynamic post-contrast images. Usually the DCE images will only modify the score if you have a DWI score of 3 that you can upgrade to a 4 based on the DCE being positive. But if you have the sequences, it's good to look for anything that might be enhancing early or enhancing focally, and then correspond it with the other sequences to see if you might have missed something at first glance there as well. And then I look at other things that I can see on the images, starting with the T2 weighted images, looking at the bladder. Okay, so often when there's BPH changes, you're going to see the bladder look thick and trabeculated like this, which is indicative of an element of chronic outlet obstruction, but looking for any incidental bladder lesions or abnormalities. I'm looking at the rectum to make sure we don't see any incidental rectal cancers, for example. I'm looking closely at the seminal vesicles bilaterally, especially if there's a lesion. I want to see if there's any invasion, for example, into the seminal vesicles, and then any nodes that I can see in the low pelvis. Then I'm looking at the wide field of view study to look for any nodes elsewhere, the vasculature, and any incidental findings on the images elsewhere. Lastly, I will also look at any wide field of view T1 weighted images that are non-fat-satted, or in this case, this is a fat-only image acquired by the Dixon method, and I'm looking at the bones to see if there are any marrow replacing lesions. So this is all fatty marrow, as we'd expect. And we want to see if in any of the bones there are lesions that might be suspicious for a marrow replacing lesion. In the setting of a prostate cancer, of course, looking for metastases. And that's pretty much it for an abbreviated approach to prostate MRI. Okay, let's apply an abbreviated approach on a couple of cases. We're not going to go through it again in detail, but we're just going to show you a couple of cases to help apply what we've learned so far. So again, I generally start with the T1 weighted image, looking for any hemorrhage. I don't see any significant hemorrhage in the gland or the seminal vesicles. Then I'm looking at the T2 weighted images, specifically focusing on the prostate itself, the PZ, which is quite small in this patient, and the TZ. Okay, and immediately you'll see that there is a clear T2 hypointense abnormality in the PZ here. And you may also notice that there is something here as well. But again, the T2 weighted sequence is not the primary sequence in the PZ. I'm just looking at the anatomy first and looking for anything that I see that's obvious. You can see the anterior fibromuscular stroma nicely here. Then I'm looking at my high B-value DWI images. Okay, and right away, you'll notice that there's something quite bright here. And when I cross-correlate, it corresponds to the T2 signal abnormality I saw earlier. And if I look at my ADC map, right, normal prostate is pretty bright, and this is pretty dark, okay? So we have a markedly restricting lesion in the apex of the peripheral zone, spanning from the anterior peripheral zone, involving the posterior lateral and posterior medial peripheral zone at the apex. It's T2 homogeneously hypointense. It's markedly restricting. I won't measure it, but it's over 1.5 centimeters. So right away, this is just based on the marked diffusion restriction in size, a PI-RADS 5 lesion. This is very likely clinically significant prostate cancer, and it was. Okay, and then higher up in the gland, we saw that other lesion, and again, we have marked hyperintensity here on diffusion, markedly hypointense signal here on the ADC map, and this is also over 1.5 centimeters. This is a PI-RADS 5 lesion as well. Then on the T2 weighted study, you're also going to look for things like frank extraprostatic extension. Here we have broad-based abutment, okay, but no frank extraprostatic extension. Here we also have broad-based abutment, but you'll also notice that there's a slight bulge here. In this patient, however, there is actually likely some neurovascular bundle involvement, but this is a finer point that I wouldn't worry about at this point. I'd also look at the dynamic post-contrast images here, and you'll also notice that both the lesion here at the right apex, as shown here, as well as at the left base in the peripheral zone, as shown here, demonstrate a positive score on the DCE images. Of course, then you also want to look at the bones for any suspicious lesions, as well as the post-contrast images with a wider field of view to look for abnormal nodes. Okay, another case. So again, starting by looking at the T1 image, you'll notice that there's T1 hyperintensity here. So there is some hemorrhage in the anterior transition zone on the left. I then look at the T2 weighted images here, and we're just going to focus on the TZ for now, but you'll notice that there isn't a lot of BPH changes, but clearly some BPH nodules here that look quite typical of BPH changes. Here on the left as well, BPH changes. But then you'll notice that there is kind of this quite homogeneous T2 hypointense region that's ill-defined. One might describe this as an erased charcoal appearance or a smudgy fingerprint. Okay, if I look at my diffusion weighted images, the high B-value DWI shows there's some marked restriction here. Okay, it's markedly high signal here and markedly low signal here. And so this corresponds to slightly higher than the hemorrhage. The hemorrhage is way down here, and the lesion is higher up over here. So this is kind of a classic TZ cancer. If you look at the coronal images here as well, you'll notice again, we have this homogeneous T2 hypointense ill-defined lesion here, here in the left TZ. And so if I were describing the location here, this is the left anterior TZ involving the base to midgland. Okay, and then I'd look at the rest of the study as well. There are no lesions here in the PZ or elsewhere. And this was a PI-RADS 5 lesion, again, based on the size and appearance. This is over 1.5 centimeters. And there's likely extraprostatic extension here as well. So this is a PI-RADS 5 lesion. This is very likely to be clinically significant prostate cancer. Okay, thank you for tuning in. Hopefully you got something out of this video. There will be another video on PI-RADS comparing version 2 and 2.1, which will really help you understand PI-RADS a little bit better, so I suggest tuning into that as well. Thank you.